Carole's with CAP-MPT, my insurance company, okay? Working in the area of patient safety, risk management, loss prevention, quality compliance, organizational development, with the Cooperative American Physicians. CAP is a California company, but it has divisions that sell policies all over the country. And they give concierge doctors incredible discounts. And she uses her experience and expertise to manage peer review processing and risk management. And I present you Carole Lambert, MPA-RN.
So thanks very much for hanging in. I always feel like it's Henry V and these faithful few at the end of the day. It's a pleasure to be here, and it's a privilege to represent my company. Those of you who know CAP know Cindy Belcher. She sends warm regards to all of you. We provide professional medical liability coverage to 12,000 physicians in California, and as Tom mentioned, through ProAssurance, we write groups and hospitals around the country. More than half our 12,000 members are physicians in 1, 2, and 3 physician groups. So the small practice is the focus of a lot of our efforts, and we've heard so much today about the challenge of survivability, and that's a lot of what I'm doing currently. My job expanded by 33% in the last month or so to include being kind of the ringmaster for our group working on MACRA and MIPS. So I was very interested to hear from Marcy this morning. Now, long-term care is a huge industry in the United States. Not all people are elderly. A significant proportion of long-term care residents are under 65, but at the same time, the population of people over 65 is growing steadily, and there'll be about 72 million of us by 2030. So that's who I am. And there are principles of drug administration in long-term care, and more generally, there are certainly risk issues which don't go away. I've been at this a long time, and the risk issues do not change. They may evolve slightly, but because we are human and we train succeeding generations of practitioners, the risk issues never go away entirely. And I want to share with you a simple strategy for responding to the challenge of medicating people in long-term care appropriately. So there are a lot of folks. There are a lot of facilities, which means there are a lot of employees, a lot of physicians, and a lot of patients. And most of them have at least 2 comorbidities and maybe more. When I was preparing this talk, I was speaking with a colleague of mine who did not work in long-term care, but who has shared my concerns over our joint careers. And I said to her, I would be really thrilled to know that the following scenario no longer takes place. And that is, you have a frail elderly person in a nursing home who is put to bed by 5:30 or 6 o'clock at night and not given anything more to drink or eat, so they don't have to be changed or taken to the bathroom during the night. So a few days of that, and you have hemoconcentration, urinary concentration, a spike in fever, an immediate transfer to the nearest emergency room where they are disoriented, frantic, and restrained on the gurney and kept NPO while they're being worked up. I would really like to know that that no longer takes place, but I have a feeling that it continues to occur. So you have the comorbidities, you have the constraints in the environment, you have the challenges of running a business whose product is frail people who need our help and our support. So the thing about prescribing in long-term care has to do, not just in long-term care, but the right drug in the right amount for the right reason at the right time. It sounds so simple, and it is so difficult to achieve because of the many pressures and conflicting agendas. So there are 4 risk issues. Now, the interesting thing about this is I met with a group of family practice residents a week ago Thursday, and we were talking about the impact of physician leadership on quality and safety. And I showed them the Joint Commission table showing leading causes of reportable events for 19, 13, 14, and 15. And the top 4 were human factors, assessment, communication, and documentation. And there were about 12 things in each column. But those 4 elements changed place in the top 4 for 3 years in a row. So communication and documentation, which usually puts my residents, medical students, and interns right to sleep, continue to be enormous challenges in every aspect of healthcare and patient care. And of course, Rob mentioned informed consent this morning in relation to testing. So here are the questions I continually ask just about every audience I meet with. What are we looking at? What does it mean? What do we have to do about it, if anything? Sometimes we don't have to do anything about it. Who do we have to get to help? Consultants, colleagues, family, community leaders. And how do we have to account for what we have done or not done? So drug-drug interactions is the first item in the title. What is the patient currently taking? You get a call, a request to prescribe something, a request to renew something. What is the patient currently taking? What's the patient's general physical status, their hydration, their nutrition? How are they going to metabolize whatever we give them? Years ago, I had a patient, it was when Alzheimer's patients, that whole process of strong, younger people developing the symptoms of Alzheimer's dementia and being institutionalized. And I worked at the Jewish Home and Hospital in the Bronx for 15 years. 812 beds, was bigger than Montefiore at that time. It's a huge facility. The other part of it had 500 beds, but I worked in the big facility. And I got this emergency call. I had to come to the male unit immediately. Someone had hit the doctor. Now you hit a nurse, it's terrible. But you hit a doctor, you have an immediate call for emergency help and a psychiatry consult. So I was the intermediate step before the psychiatrist. So here's this tall, angry guy, hit the doctor, rolled his wheelchair into the nurse's station, banged up the furniture. He was put to bed, he was restrained, all his medications were stopped. He was evaluated by psychiatry and by internal medicine, and in 3 or 4 days, they restarted all his prescriptions. And about 5 weeks later, I got an emergency call. He had hit somebody. So I got out his record, and I looked at, he'd been with us a long time, so I looked back. Over a 2-year period, he had done this, this cycle had occurred 19 times. 19 times. And he was always put back on what he had been on. And he had digitalis toxicity. And we solved the problem by giving him a drug holiday on the weekends. So he had 5 days of medication and 2 days to metabolize it and excrete it. And of course, what's the family giving the patient? At the end of the presentation, there's a slide with 2 websites on it. One for drug-drug interactions and the other for herbal remedies. So, real story. Patient is in a nursing home on digoxin with an order for amiodarone. Was the order current? Was the order new? The on-call physician gets a call from the nursing home. The prescription has expired. Can she renew it? The physician did not know the patient, wasn't familiar with amiodarone, and renewed the prescription. And the patient died because they don't go together. They don't work together. So you have a patient who, living at home, loved fresh grapefruit. Family comes to visit regularly and brings fresh grapefruit. The patient's on a statin. Doesn't work. So what's going on before you write the order, before you renew something? And then, of course, all the herbal stuff that patients' families have looked on the internet, and it's going to help them maintain skin integrity, maintain their intellectual capabilities, and they bring this stuff and they don't tell you. So on average, 1 in 10 nursing home residents is receiving antibiotics on any given day. That's approximately 140,000 people. That is not the people out in the community with legitimate prescriptions or the people taking the antibiotics left over from a previous illness or from a relative. That's just theoretically in a controlled situation. So I was so interested and so heartened to hear Tom this morning talk about calling Jeff about a patient traveling from California to Connecticut and that very effective transition of care. One of the big presentations we've done and broadcast has to do with transitions of care. And people who don't deal with patients and families and lawsuits and claims and indemnity payments say to me, transitions of care is not sexy, Carole. That is not an attractive topic. That is going to bore people. And my answer to that is, I'm sorry it's boring, but it figures in so many claims and lawsuits and results in so many indemnity payments. So it may not be sexy and it may not be attractive, but it's very important. So the effective transition of care between these two physicians was not evident in a case we saw a week ago Wednesday, where a physician on call was advised of a transfer of a patient. She was coming, she was on 2 broad-spectrum antibiotics. Okay, the patient came with documentation that did not reveal any clinical rationale for 2 broad-spectrum antibiotics. Blood cultures had been done, the reports weren't back. So the on-call physician asked a colleague to see the patient. Physician saw the patient, no clinical indication for the antibiotics, discontinued them. The patient was moved on to another facility. 2 days later, the blood work reports came back, the patient had MRSA. Now, the bugs that were bothering her had just enough time with those antibiotics to perhaps become stronger and resistant. So you're creating trouble for patients, for staff, and communities. Now, in the scenario I described to you at the beginning about the patient spiking a temp and being transferred to the hospital, infections are the most common cause of these emergency transfers that are disorienting. And in my own experience in the Bronx, you send an acutely ill elderly patient over to Bronx Municipal Hospital emergency room, and the young resident looks at the patient and says, they're over-medicated, there's nothing wrong with them, hydrate them and send them back. So very ineffective. So the facility calls and wants action. Do something. They want action. They want an order, they want to fix something, they want to solve the problem, they don't want to have to worry about it or think. So the physician responds in a considered and thoughtful and thorough way, asking for information. Joe Grenny and his colleagues wrote a great book together called Crucial Conversations. If you don't know it, you should look at it. It's really important because we need all the information possible in order to make the best decisions. And it doesn't mean that we agree, but we need all the information in order to make the best decisions. So the physician says, okay, I want to know enough about the patient before I start telling you to do things. And are we going to keep the patient in the facility, in the long-term care facility, or send them to the hospital, which brings other risks with it, as we know. If you're going to treat the patient in place, the usual, customary, important workup has to take place. What are you going to do? How are you going to measure success? How are you going to account for what you've done? What is your treatment rationale? What kind of follow-up? You know, one of the things that's not on the slides, but I hope is implied by the slides, is the importance of preparing the staff at the nursing home to respond in a thoughtful way and present you with good information. That takes training, that takes rehearsing, that takes follow-up all on its own, because the staff in the trenches have a contribution to make and a role to play. And we need to mine their information as well as bring our own expertise. The right drug in the right amount at the right time, it's magic. It's magic. What the proper use of antibiotics can achieve. So that is something very important to keep in mind. You can get a magic result by using things in the proper way, having the right support, the right information, the right preparation of the staff you're working with. Let's change gears completely to look at this other very important aspect. Again, 15 years at the Jewish Home and Hospital, and I can tell you that it was a challenge to have the physicians prescribe appropriately for people in pain. We'll mask their symptoms. Really? If they're in such pain they can't communicate effectively, or they can't access their own coping mechanisms, what are you helping? We'll turn them into addicts. You know and I know that treating pain appropriately before the crescendo, before the demand for more because they're not getting relief, does not result in addiction. Far from it. We'll get sued. Well, I'm going to use a technical insurance term here. People are crazy. People are crazy. Families are going to say crazy things about you. I don't care how fabulous you are. People are going to accuse you, it is just the way of the world. But getting sued, the response to that is going to be in your documentation. How do we account for what we've done? So it is perfectly true that there is a serious problem with prescribing and overusing and people dying, especially women, unfortunately, from opioid overdoses. The medical board in California, who practices in California? The medical board in California is landing on physicians. I mean, the sky is falling. The list of accusations, I get a regular report every Friday, the list of accusations against physicians for inappropriate prescribing or overprescribing is long. People are going to prison. People are going to jail for this. And the lack of accountability now has brought this huge, huge spotlight shining on physicians and making people afraid to prescribe appropriately. And of course, there is criminal activity. Patients do shop around and collect drugs and sell them on the street. Like I said, people are crazy. Some people are terribly dishonest. Some people are terribly damaged. And it all comes back to fall on physicians who need to be so vigilant in protecting their patients and themselves. So, you want to plan for chronic pain management. And these are the same principles that you're familiar with in other parts of your practices. Medication selection. What is the best thing? Again, what's the patient taking otherwise? What's the patient's general health? The well-hydrated, well-nourished, active to whatever degree possible person with intact skin, they're going to be a better candidate for some things. But people who metabolize drugs very slowly, we heard about that this morning. If you metabolize drugs slowly, you're going to need less, and you may need it less often. So what are we trying to achieve with pain management? We're going to affect people at the cellular level. So what are we trying to achieve? And how are we going to measure that? What are our benchmarks of success going to be? And how are we going to differentiate very clearly between sundowning, which in an elderly nursing home patient with dementia is a natural process, it's part of every day, and a real change in mental status. Again, the right drug in the right dose at the right time, it's magic. Pain relief, I'll tell you not a nursing home story, but a palliative care story. I had a pair of neighbors, a couple across the street, such fabulous people. Such fabulous people. And they were in their early 80s, and the wife was short of breath. And she was a tiny thing, maybe 100 pounds. And she had a very rare sarcoma growing between her lung and her rib cage. They operated, she had chemo and radiation, and when she went back for a 6-month checkup, she had many new tumors. So it was just a terribly aggressive disease. And she stayed at home, she was on hospice, and I went over one evening. I had been preparing food for them and helping out as I could. And I had never seen anyone in all my career writhing in pain. You read about it, but seeing it is something else. This woman on the couch twisting to get away from the pain. And these are both college-educated people. They had conferred with the hospice team more than once. And I said, isn't she getting pain medication? Oh, yes. Well, does she need more? Yeah, I'm trying not to give orders. And they said, well, the nurse said she would visit. And I said, I think you need to call the nurse and get a consultation because she's too uncomfortable. And then we had later on the conversation about being comfortable and having as much interaction as you wanted, as long as you wanted. But that was an educational process that, for all their smarts and all their sophistication, had not really registered with them because of the baffle created by her condition and the prospect of her not living much longer and the tremendous loss the family was experiencing. Again, educational, everyone has a contribution to make and a part to play, but we need to know as much as we can. So what am I looking at? Physical assessment, chart review, staff interview. Ask the staff. The best information and all available information. What does it mean? You know, I talk very often about what the work means. The work has meaning beyond the task. We're not just checking boxes or following an algorithm. We're actually looking at a person in a context, and we bring everything we are to the situation, and then we have to assess everything that is in the situation. The family situation, culture, gender, age, communication styles, so many things go into making a thorough and complete assessment that has real meaning. So do we need to do anything? When comfort measures have failed, what do we need to do? Always educating, always sharing our knowledge and expertise so that we lift everyone with what we're doing and setting goals and measuring. We need to keep track of what we're doing, and we need to be able to account for it. How about getting everyone to help? Community leaders, colleagues. One of the traps for family physicians, internal medicine, family physicians, general practitioners, in pain management has to do with beginning to prescribe for a patient you know well and prescribing too long. Not necessarily too much, but too long. Because the claim becomes that you practiced beyond your scope, you deferred, you delayed referral, you delayed assessment, you delayed treatment, and you contributed to the progression of disease. That's a risk. That's a risk that we have dealt with in our company over and over again. At the other end is the psychiatrist who accepts the patient and prescribes for the patient without saying, when did you last see your internist family practitioner, and getting a thorough assessment. How do I have to account for it? This is where we'll get sued, comes up against the bedrock of really good documentation. Accurate, timely, precise, clear, so that the person following you can appreciate the chronology of the patient's experience, the rationale for your decision making. The last time we met, last time we had a meeting, one of the records was full of one physician saying about another, I have no idea why Dr. So-and-so did such and such, which is extremely unhelpful, not to mention deadly. So the rationale for treatment decisions, the measurement of success, the ongoing assessment, the involvement of appropriate people, that documentation is bedrock to stand on. So when people go nuts, or you're challenged, or someone calls the medical board and turns you in, and you send your records, and the medical board says, we have investigated this matter and no further action is indicated. That's the letter you want to get. And that will be based largely on what can be read in the record. So for me, a career in long-term care, all those years I spent in long-term care, it was a fascinating and rewarding and educational experience. But it highlighted the role or the position of long-term care in the wider healthcare community. And I had at one point a critical care nurse say to me, "Oh, you work in long-term care. Well, you're not good enough to work in acute care." It was very warm and encouraging. So that elitism, or looking down your nose at long-term care. And the other issue, of course, or there are really two other issues. There's a philosophy about long-term care. That's principles and values. What are our values about caring for people in long-term care and nursing homes? And then there's the politics of long-term care, and that's money. Who's going to pay and how much? And are we willing to pay for the best people to work in long-term care? And that led me, of course, to Gandhi about how are we going to be judged by the care we take of the most vulnerable people, the least fancy people in our society. And about 40 years ago, Victor Fuchs, I checked, and I think Dr. Fuchs is still with us. He's emeritus at Stanford, and he wrote a book called Who Shall Live? And somewhere in that book or in the interview about it, Dr. Fuchs said that a nation chooses its mortality rate when it writes its budget. That's a sobering thought. So those are things that come to mind when I think about the place of long-term care, the need for it, but the place of it in the wider picture of healthcare delivery, and about our values and the value we place on it. So it's a challenge. I have no answers. But I think it is always something worth reflecting on in case someday someone we know or love or ourselves needs it. The work has meaning beyond the task. We need everyone to get the safety and quality job done. We can't assign it. It's a non-delegable duty of being a human being. And people are counting on us. It's a wonderful quote about the extraordinary healthcare experience, which is something I've written about and talked about a great deal. Our job is to help people live out the best life they can, to achieve their dreams, to lead healthier lives. That's both our charge and our commitment and our promise. So thank you very much for being here, for sticking with me. I'm all that stands between you and a glass of wine, and I know that. So I hope to see you all again. Thank you very much.
We are early, and you have plenty of time to questions.
What did I do? I turned it off. Yes, Jeff.
I have a question maybe for the room in general. In my situation, I am not on any of the local nursing home rosters. So when my patients are discharged post-surgery, post-hospitalization, they're being taken care of by the nursing home physician in addition to me. That brings up complexities as it relates to I'm the one getting the email and the text message and the phone call from the family saying, what's up, why is this happening, what can you do? Can anybody in the room, including yourself, give me some thoughts as to how to manage that more effectively?
Do you have a relationship with the nursing home physician? Do you know who it is?
I'll know the individual, but I don't have a great relationship with most of the physicians that are there. Many of them are outside of my community doing it, on call, et cetera. So.
Okay. You had raised your hand.
Yeah, I've reached out to the nursing home doctors. I've actually also stopped by the nursing home just to, like maybe on a weekly basis, to review what's been going on, to see if there's any medications that are inappropriate. And I don't necessarily charge for it, but that's part of what we do.
Yeah.
I have had some instances where there might be what you call blowback, but my reverse blowback ability is very high, a la Donald Trump, in terms of giving it to them and basically putting things in a very unique perspective as to whose patient it is. So I don't really care what they say or what they think.
But you have to watch out for being labeled a disruptive physician.
Yeah, right,
My solution to that problem, frankly, is I take care of my own patients in the nursing home myself directly. I don't use the nursing home
But
doctors.
you can't, you,
We've got 15 and 20 nursing facilities in the area
Yeah.
that patients can go to. There's not just one down the street.
Yeah.
yeah.
Yeah, I do too, but I only let them go to 2.
Yeah, but I think if the patient's still contracted with you to provide concierge medical services, or there might be, you know, an obligation to do something. I visit my patients like you do. In Durham, there's Big Duke Hospital, Durham Regional, and then how it's called. Wherever they're at, you know, I'll find them and show up as a visitor. And a quote visitor, but my experience has been favorable in that the person who's the attending or might be a nurse practitioner or a physician's assistant in the nursing facility, you know, if you approach them in a collegial way and say, yeah, I'm a local doctor, but this has been my patient for 20 years, and every time I did such and such, he kind of wound up like this, and what works for me is such and such. It's sort of a friendly way. Works pretty well.
That's good step one, you know. If you have to become the heavy.
I actually do the same thing Tom does. I actually go to them, so I get to see all the stuff that's not done, even the continuity of care going out of the hospital. But the one thing is, most of them now, the ones I don't go to, I've gotten on their electronic medical record, so I can at least check stuff now, which is actually very helpful if you're going to 11.
I also asked the nursing home to send me a list of the medications. And they say, who are you? And I said, I'm the attending doctor. Are you on staff here? No. And, you know, then I start, you know, mentioning HCFA, all kinds of initials they don't want me to mention, and say, just go ahead and do yourself a favor and send me the medication list. But, you know, there's various ways you can do it.
Marcy has her hand up.
So, you know, the 15 nursing homes, you know, look them up on the Medicare website. There's only 2 of them that are 5-star. The rest of them are 1s, almost always, or 2s. Why would I ever let anybody go to anything but a 5-star nursing home? That's my feeling. And there are only 2 in my community. It's the only 2 I use.
I find that we have to get back to old-time communication. Pick up the phone, call the treating doctor, call the treating nurses. Hey, I'd like to help you. This is Mrs. Smith. This is what happens. It works. The old way is just still the best way. We've gotten behind computers too much, guys. We have to go back to old-time medicine. Remember, it's about relationships. You need to create a relationship with the nurse and the doctor that's taking care of the patient. Give them a reason to want to do a good job, and just give them a call. It's easy.